So good morning to everyone. Thank you for this kind introduction. Unfortunately, I'm not be able to be present in the wonderful city of Ioannina, but however, I'm very pleased to give this lecture online. So what we are talking about is how can we approach polysensitization in the diagnosis and treatment of Hymenoptera venom allergy. So what tests we have available, you all know, of course, what we have. We have the skin testing, we can do the prick testing, the intradermal test. We can do, or we can determine specific IgE to the whole venom preparations, for example, to bee venom and waspid venom, and we have also the possibility to determine IgE to molecular allergens, for example, APM1, 10, VSV5, or so on. And in some centers, we have also the possibility to do cellular tests, such as the basophil activation test. Let me just say some words about the diagnostic procedures. I mean, I don't know if you do the prick testing. Prick testing is possible to diagnose insect venom allergy, but you have to be aware that sensitivity is quite low, especially in bee venom allergy, around 73%. When we look at waspid venom allergy, it's around 85%. So the gold standard in skin testing is, of course, the intradermal testing, where we inject small amounts of venom into the skin, and we have very good sensitivities between 91 and 96%. So how can we fasten this process? We should, simultaneous injections of different concentrations should be possible. It shouldn't make a difference if we just inject the highest dose with 20 nanograms, or if we check 4 injections at the same time with 22.22 nanograms. And indeed, when we look at the literature, there's now strong evidence that the simultaneous approach does not increase the frequency of adverse events. If you look here to this is our publication from 2013, 0.6% had systemic reactions, and this was also confirmed in a Canadian study with 0.3% of adverse reactions. So if you do skin testing, if you do intradermal testing, you have to be aware that systemic adverse events may occur, but it's generally safe. And if you do it simultaneously, you save time for both the patients and you and your staff. Looking at the specific IgE determination, we have also to be aware that sensitivity of bee venom is not that high. It's 87% compared to 94% for waspid venom. We can increase this sensitivity if we use the lower cutoff, especially in patients with low total IgE. We cannot lower the cutoff in all patients, otherwise specificity would markedly decrease. But if we lower the cutoff to 0.1 in patients with total IgE below 30, as you can see, you can increase sensitivity from 87% to around 94%. And if you combine the tests with the intradermal testing, we have a sensitivity of almost 99%, which is really good for diagnosis. We have the same thing with waspid venom allergy. We have already a high sensitivity with the normal cutoff, 94%. But again, if we lower the cutoff, it increases to 98%. And if we combine it with intradermal testing, it's 99%. Of course, we can also do molecular allergy diagnosis in insect venom hypersensitivity. It's indeed, molecular allergy diagnosis are also called component resolved diagnosis, is a big step forward in allergy diagnosis, especially in pollen allergy or food allergy, where you can detect propylene sensitization, porcalcine sensitization, or exclude sensitization to cross-reactive carbohydrate determinants. In insect venom allergy, the use is a little bit limited. Sorry. I hope you can see it, still see it. Yeah. We have 12 allergens. In bee venom, 12 known allergens in bee venom. The allergens in red are available for routine diagnosis, and the allergens with the asterisks usually have CCD, so they are prone to give false negative results if they are not recombinantly produced. So usually all allergens we have available do not include cross-reactive carbohydrates, only if you use the natural ones. Then we have this influence of CCDs. And as you can see, Vespid venom has only 5 allergens, and 2 are available, but those 2 are very important allergens and usually sufficient to diagnose Vespid venom allergy. We have 3 candidates for cross-reactivity. It's the hyaluronidase, it's the dipeptidyl peptidase, and vitellogenin. So the sequence identity is not that high, it's around 50%. Hyaluronidase, cross-reactivity of hyaluronidases is mostly due to CCDs, but sometimes cross-reactivity on protein level can occur. Most important is dipeptidyl peptidase. So this is also what we can diagnose. We have the hyaluronidase, we have the dipeptidyl peptidase, but unfortunately we don't have vitellogenin, so we cannot detect cross-reactivity due to vitellogenin. When we look at the sensitization pattern in patients with bee venom allergy, we have a lot of allergens and we have a very broad sensitization pattern. So it's not a single allergen that is important in bee venom allergy, but the problem is that the sensitivity of this panel is quite low. It's only 72% compared to 87% of the whole venom preparation. So we have to be careful because we miss 28 patients out of 100 if we just do this panel. It's a little bit different when we look at the sensitization pattern in Vespid venom allergy patients. We have only a few allergens and we have an acceptable sensitivity of this allergen panel. It's around 91% compared to 94% of the whole venom. In specialized centers, we have also the possibility to do the basophil activation test. The basophil activation test is based on the fact that usually CD63 and histamine and so on is located in the granules of the basophils, and only after activation of the cell, after cross-linking of 2 identical Fc epsilon receptor bound IgE antibodies of the allergen, we have the release of mediators, and then CD63 is on the surface and can be readily detected by flow cytometry. But again, sensitivity is lower compared to IgE determination, around 73% and 84% in Vespid venom allergy. So this is data from a very old study of our center, but just to show you that the basophil activation test had the lowest rate of double sensitization. And we compared at this time different types or different methods of IgE determination. The ADVIA system was a very good system to detect IgE, but it unfortunately disappeared from the market. The intradermal test had around 50% double positive results, and when we look at the CAP system, it's around 60%, at a frequency of 60% of double positive results. The alternative method of IgE determination is the Emolite system, but it's also not better, also around 60% double positive results. So driven by these results, we wanted to know if the basophil activation test is able to find the relevant venom for immunotherapy, and that's why we included 29 patients who were initially double positive in the intradermal test and in the IgE determination, but only single positive in the basophil activation test. And what we did, we sting challenged patients with the bad negative result. And what we found is, unfortunately, the two still had systemic symptoms, only mild symptoms, admittedly. The first patients had some wheals, the second flush and mild dyspnea, but anyway, they were not symptom-free. So we can conclude that the basophil activation test only seems to be a reliable tool to exclude moderate and severe reactions. So you may overlook slight or mild reactions. So every method, every test has, unfortunately, its drawbacks. So no test is perfect. So therefore, we developed a rule of thumb. It's not very scientific, but at least it has been calculated from the statisticians. And if you sit in the private practice and you just want to know maybe the relevant venom, so we have this simple rule: if Vespid venom, if IgE levels to Vespid venom are 2.7-fold higher compared to B venom, you can be quite sure that this is the relevant venom for immunotherapy. We have a high specificity for this calculation. Of course, sensitivity is not too high, but that's not the point here. We need a high specificity. We have to be sure that Vespid venom is the right venom. We can do it also for B venom in B venom allergic patients, but here we need higher levels for B venom to be sure that it's actually B venom allergy, because B venom contains a lot of cross-reactive carbohydrate determinants, and so we can expect higher levels of B venom IgE if IgE to CCDs are present. But if it's around 5-fold higher compared to Vespid venom, you can be also sure that that B venom is the primary, or that B's were the primary sensitizers for this allergy. So to sum up diagnostics, and then we will talk about some cases. Sensitivity of the diagnostics with B venom is always lower. So that's what we have to keep in mind. Specific IgE determination and intradermal tests have a comparable sensitivity, so they are both gold standards, I would say, to diagnose insect venom allergy. Prick testing and the basophil activation test have a lower sensitivity, but in combination with conventional tests, they might be useful. And we have molecular allergy diagnosis, very useful in pollen allergy, in food allergy. Here, in insect venom allergy, it's limited, the usefulness is limited to this low sensitivity. If we lower the cutoff in patients with low total IgE, we can increase sensitivity. That's a very good tool, very practical tool. Also what you can do in your practice if you don't have a lot of tests available. And as already mentioned, the combination of tests increases sensitivity. So you should always think of this, even if you just combine specific IgE and prick testing, it increases sensitivity. But now let's go to practical cases and to warm up. I have case one. It's not double sensitization, but I just want to show you that sometimes personal history can be misleading. So we have a 9-year-old girl. She stepped on an insect in the clover meadow, very typical sting on the sole of her foot. And of course, the stinger remained in the skin because she stepped on the stinger, and parents suspected it was a bee. And I guess all of you would think the same of this. Symptoms were moderate, urticaria, slight dyspnea, some dizziness. So for kids, it's already a very moderate or severe reaction. But when we look at the results, we see just Vespid venom is positive, B venom is negative in the IgE determination. So could that be a lab error? Was there something messed up? But when we also do the intradermal test, again, Vespid venom positive and B venom negative. So we could exclude that it has been a lab error, but what could be the reason for that? First, we have to say we all know that during the sting challenge or after the sting, the bee stinger is left into the skin because it has barbs on the stinger, so it usually stays in the skin. But what we sometimes not think of is that also wasp stingers have small barbs on their stinger. And if there is pressure on the insect, if you step on the insect or if you sit on the insect, it's also possible that the stinger remains into the skin. So it's not a safe sign that it has been a bee sting. If you stepped on or if you sat on the insect, it could also have been a wasp. And the second thing is, of course, we are bothered by the wasps in fall, in autumn, when the population is getting very big and they are getting really hungry. So, but usually they eat also pollen and nectar, and they need only sweets and meat. If the population is rapidly increasing, especially meat, they need proteins for their larvae, and this is mostly the case in fall. So then we notice the insects, but they can also be in the meadow and then collect pollen and nectar. So to conclude this case, a waspid stinger can also be left in the skin, but only under pressure. Yeah, so therefore you have always to ask if there has been pressure on the insect. If yes, you have to be, you cannot be sure that it has been a bee sting. And wasps also eat pollen and nectar, and so they can also be in a meadow. So sometimes, I admit this is not a very common case, but you can see sometimes it could also be a wasp, even if you think it has been 100% a bee sting. Let's move to the second case. We have a 40-year-old man. He got stung on the arm during a lunch in the garden. Symptoms were, I would say, moderate urticaria, angioedema, laryngeal dyspnea. When we look at the diagnostics, total IgE, high total IgE, clear sensitization to waspid venom, weak sensitization to bee venom. And now in this case, so I mean, it's a little bit artificial, but you have no skin test available. You have no molecular allergy diagnostics available. So what you can do here, and this is what I already showed to you. This is a very easy rule of thumb. Think of this rule of thumb. We have here a clear sensitization to waspid venom. The personal history indicates that it could have been a wasp. The person was eating outside, and we have the specific IgE to waspid venom is 5-fold higher for waspid venom. So this is a very practical rule of thumb to determine the relevant venom. Next case, we have a 55-year-old man. He got stung on the back while walking in the park. Symptoms were dizziness and loss of consciousness, so we have a very severe reaction. The results, total IgE is low. We have specific IgE to waspid venom and to bee venom, so the levels are quite similar. And if you have the intradermal test available, you will also do the intradermal test. Again, positive for both venoms. And if you also have molecular allergy diagnosis available, you can do that. And as you can see, we have sensitizations to allergens, to bee venom allergens and to waspid venom allergens as well. So those who are experienced with molecular allergy diagnosis, you can see we have here true double sensitization. All tests are double positive. And in combination with a severe reaction, we have to treat with both venoms, because we are not able to distinguish between waspid and bee venom allergy. The initial reaction was very severe, and then we always recommend treating with 2 venoms, then you are on the safe side. It could be that one sensitization just causes large local reactions, we don't know. We cannot distinguish between asymptomatic sensitization, large local reactions, and systemic reactions. But in this case, a double therapy with bee and waspid venom would be advisable. So then we have case number 4. We have a 40-year-old man. He got stung to the face while riding a motorcycle. Also very difficult to differentiate between a bee and a wasp. Symptoms, moderate symptoms, urticaria, nausea, dizziness. And looking again at the IgE determination, we have a high total IgE, again, specific IgE to waspid venom and to bee venom. And when we do molecular allergy diagnosis, if we have it available, then we see it's just sensitization to APM5 in bee venom and a clear sensitization to WESV5. So this is the only case where molecular allergy diagnosis can be helpful. When we look again at the cross-reactive allergens, it could be hyaluronidase, APM2, APM5, and APM12. We just have APM2 and APM5 for differentiation. But when we look at the diagnostic algorithm recently published, the update was recently published, so this is the only case. If only APM5 is positive, we can assume that this sensitization is mainly due to cross-reactivity to waspid venom due to cross-reactivity of the dipeptidyl peptidase. So in this case, we have a clear sensitization to WESV5. We have only sensitization to APM5. So in this case, I wouldn't do immunotherapy with bee venom. So now let's come to our last case. We have a 25-year-old woman, sting to the thigh while sitting on the park bench near a trash can. Symptoms, drop of blood pressure, dizziness or moderate symptoms. And we can see very high total IgE levels, 1200 kilounits per liter. We have sensitization to waspid venom, to bee venom. Bee venom specific IgE levels are higher compared to waspid venom. And this is a possibility I want to show you if you are in an academic institution, if you're just interested in that. You can do CCD blocks, so you can add cross-reactive carbohydrates to the serum of the patients, and then after that you determine IgE again. And as you can see here, the bee venom levels almost decreased to 0, not completely to 0, but this is mainly due to technical problems or technical reasons. So usually you cannot come to 0, especially in insect venom allergy. This blocking works really well in food allergy, in pollen allergy, but CCDs in insect venom allergy are a little bit different, and therefore it's not possible to completely block all CCD antibodies. But there's one important point, and it's sometimes recommended in guidelines, that you should determine specific IgE to CCDs that can be useful to evaluate if CCD antibodies are present. And it's again an old study of our team, but what we found is we did Western blot inhibition experiments, and patients can have CCD antibodies and true sensitization at the same time. So that's a problem. So around 50% in our study population had true double sensitization and CCD sensitization. And more importantly, on the other hand, when we saw that double sensitization was caused by CCDs in the Western blot inhibition experiments, only 50% were positive in the IgE determination to CCD MUX-F3. So that means this determination has a very low sensitivity and is not useful at all. So save costs, save money, and don't do this this IgE determination. Of course, if you want to do it very strictly and easily, you can do the intradermal test. The intradermal test is usually negative in patients with sensitizations to cross-reactive carbohydrate determinants. So if one sensitization is only caused by CCDs, this is usually be reflected in the intradermal test. So to conclude, and this is also a very important point, venom contains more cross-reactive carbohydrate determinants. Therefore, specific IgE levels to the whole venom could be higher, even if the venom sensitization is not the relevant sensitization for immunotherapy. Double sensitization in this case is due to CCDs, and a red flag is always high total IgE. It does not matter if in pollen allergy or food allergy or insect allergy, if you have high levels of total IgE, CCDs may be present, and in food and pollen allergy also prophylines or polycalcines or other cross-reactive allergens. So this was the last case, and I come to the conclusion. So what kind of methods we have to identify the relevant venom? We have a simple rule of thumb. If vespid venom is around 3-fold higher compared to bee venom, or bee venom 5-fold higher compared to vespid venom, you could be sure that this is the relevant venom. We have molecular allergy diagnosis with the limited use, but it's helpful if only APM5 is positive. CCD block may be very helpful, but the primary indication is pollen and food, but you can also do the skin testing, the intradermal testing. We have the basophil activation test, and what I did not mention before, of course, the CAP inhibition tests, but all tests have their drawbacks. CAP inhibition needs higher levels of specific IgE to get reliable results, so it's not always so easy to find the relevant venom. I didn't mention polystes here because we don't have a lot of experience with polystes in Austria. We have polystes, but we don't have stings and allergy to polystes. But at the moment, it's very difficult to diagnose, to differentiate between Vesper and polystes, because we don't have all molecular allergens available. We have a high cross-reactivity between these allergens, and usually in doubt, you have to perform immunotherapy with 2 venoms. So now I'm at the end. I hope it was a little bit interesting for you. And finally, I want to thank my small but very dedicated working group for their great work. And I'm looking forward to a lively discussion and to your questions. Thank you very much.